got a lot of experts here for this webinar, and we're very happy that they are here. So we will just do a quick introduction. This is a webinar for Mass Peace Action, promoting healthcare, not warfare. As you know, healthcare budget, the warfare budget for the U.S. is 2/3 of the federal budget. So those are weapons of war that are not going to public health, to community health, to schools, to roads, bridges, anything. They are, all that money is going to the bombs that they are dropping, the additional $20 billion going for more bombs to Gaza. So we are pretty outraged about that, but we do want to target in on the issues around Steward Health Care. We in Quincy had an opportunity to try to fight Steward Health Care 10 years ago when they shut us down, when they shut 6 Caritas Christi hospitals down in Massachusetts, along with Quincy Medical Center. So we really do know personal experience how appalling the Steward Healthcare scheme is really. And I want to mention that we did have a webinar on the issue on April 24th. So you can go to our website, Mass Peace Action website, on Steward Cerberus and Your Health. For the first, we had Katie Murphy from M&A, Alan Sager from BU School of Public Health, and Sandy Eaton. Today, we have more specialists and experts. We are thrilled to hear from Peter Knowlton, is co-author of the white paper for Mass Peace Action. He's been a labor campaigner and an activist for many years. We also have Dr. Steffi Woolhandler. And Steffi has been a national leader for the National Health Care, it's the Physicians for National Health Care. I'm pulling up my notes here. And also doing public health at a national level. She's published extensively, and we will have some references to her material in the resource packet that will be going out in the end. And last but not least is the Reverend Dr. Sabina Martin. And Sabina has been with the Poor People's Campaign and been very active as an advocate, housing advocate. She's been an advocate for many issues. She's also a veteran. We are both veterans. We got caught up. Well, I was Vietnam. But Sabina, yes, has also had the veteran experience. So she's been terrific, and we thank her for being here. Thank all of you for being here. So I think we've got most of our people. Have they joined? Why don't we get started? Peter Knowlton is the first speaker, and he's got about 10 minutes to speak on the white paper and whatever issues you want to discuss, Peter.
Thank you, Bonnie. And I want to thank MAPA for pulling this together. This is a very important discussion, incredibly timely, especially with the latest developments with Steward. And I am also on the board of Mass Care in Massachusetts, and I come out of the United Electrical Workers, the UE. I was in the UE for 35 years and retired in 2019. So I am not actually anything emeritus, but I am a retired member of UE. So despite the whole thing, we don't have emerituses. We don't have emerituses in the UE. We just have people who are retired and then continue doing the political work that's necessary.
Continue to do the good labor work.
Yeah. So I am supposed to talk about eminent domain, and the reason is because it's been raised. We've been raising it in Mass Care and developed a white paper. Myself and retired international rep with UE, Dave Cohen, who lives in Greenfield, have had a lot of experience with eminent domain in our own work in the UE for a few decades, starting in the mid-'80s. Actually, is when the UE developed its theory and its campaign and its practicum around eminent domain and how we could save jobs and save factories with municipalities, redevelopment authorities, even port authorities, potentially municipalities, the state, could save jobs by seizing factories that are scheduled for closing. UE was one of the main manufacturing unions in New England for many, many decades. Tens of thousands, if not over 100,000 members at one point throughout New England. Deindustrialization in the 90s, starting in the 80s and escalating in the 90s, really eviscerated manufacturing, as any of us knows who lives in the area. What happened not just to Massachusetts, but to our entire country, with offshoring, sending jobs to all different countries overseas. Labor was really struggling how to react to it. In fairly typical UE fashion, we came up with the idea of, eminent domain. It is a long, it's a concept that's been around a long time. I would say several hundred, if not 1,000 years. It is just a well-known principle that government or leaders of society have the right to take private property for the public good. And that is essentially what eminent domain, that's all it is taking private property for the greater good of the community. And then giving that person you take the property from, or company you take the property from, giving them a fair market value based upon how the facility is being used at the present time, not how it potentially could be used as a tourist attraction or as, say, it's on the shore, as a luxury resort, but what it is at the present time, be it a factory, be it a hospital, whatever. So that's and that's what Steward is doing now. For those of you who've read the newspaper, they're challenging the Healy administration's taking of St. Elizabeth's, which she finally is doing that one, which we're happy about. And the dispute will be around how much is St. Elizabeth's worth and what the state should pay Steward to take it. So it's been around a long time. The only that we know of, the only known case of a company actually being taken, with the exception of a hospital like this, of being taken for the public good, was a laundry back during World War II that was taken over for federal government purposes. I'll give you another example that some people might know, which is there used to be a team called the Baltimore Colts. They're no longer called the Baltimore Colts. They're called the Indianapolis Colts. And they became Indianapolis because the owner didn't like what the legislature was doing when they were trying to build a new stadium. So said, fine, we'll go to Indianapolis. The legislature actually passed legislation in the middle of the night to seize the Baltimore Colts by eminent domain. But the company already knew what the deal was, and they had packed up all the equipment, all the training equipment, everything that belonged to the team, put it in a bunch of semi-trailer trucks, literally that same night. And the minute those trailer trucks crossed the state line, it was done. The deal was done. There was nothing that could be done. And this is one of the things that we learned very early on in UE about eminent domain, is it has a very clear beginning and an end. The beginning is when a corporation or an entity decides that they're going to do something to deprive the community of jobs, of a healthcare facility, whatever it might be. And then you have a certain amount of time to react to try to reverse that decision. In the labor movement, we basically have 60 days because that's the Workers' Assistance Relocation Notice Act that was passed in the 80s. Basically gives workers and facilities of 100 or more the ability to give us notice as workers, but we only have 60 days. So almost all of our eminent domain campaigns in the UE have happened within a very short time frame. Here, by state law, they're supposed to give 120 days notice. We don't, in mass care, we don't think they are. And that's one of the things I know that there's been a complaint issued against Steward based on lack of notice. And there's an article I read today about people challenging some of the Steward not following the law and the state not forcing Steward to follow the law about what you do when you close a healthcare facility. But aside from that, with eminent domain, what we're used to with it is we use eminent domain, the government does. What I'm used to with historically for me is taking farms, taking small businesses, taking homes for highways, power plants, power lines, redevelopment, which usually meant destroying a Black and brown low-income community or just a Black and brown community and replacing it with a shopping mall, replacing it with a stadium. The arena for the Pittsburgh Penguins was a whole community was taken just below what's called the Hill in Pittsburgh. And it's been a real famous community, and the whole community was just completely destroyed just so that they could build an arena for the Penguins, and that was taken by eminent domain. So the uphill battle we have initially with eminent domain sometimes is getting people to see that there's actually a good way to utilize the law in a way that supports our communities and supports human endeavors and doesn't just sit there to line the profits of corporations or individual owners, doesn't line their back pockets. But we have to get beyond that hurdle of our history in our country of how it's been used historically. And for obvious reasons, there's a lot of people who just have a real hard time with it. But once you explain to people that that may be the history, but we could rewrite a new history based on human needs, based on our need for healthcare in this particular situation, and using it for the public good. So right now, MassCare has been putting together the white paper. We've been shuffling it off to a lot of different legislatures. We sent it to the governor, sent it to the AG, sent it to all the legislators, sent it to all the municipalities that were involved, that had hospitals that were slated for something to be done with them once the Steward debacle started. We've gotten a very positive response. I'm not particularly surprised by the response, and I'm very heartened by it. Although there hasn't been yet, for instance, Dorchester or any of the communities in the Nashoba Valley, nobody stepped up yet to try to seize the hospital for eminent domain, which municipalities have the ability to do. It's basically municipalities, redevelopment authorities, the state legislature, the governor, and there's a few other entities that have the ability to take property by eminent domain. So it hasn't, the governor did it with St. Elizabeth's. We think she did it with St. Elizabeth's because it was a quote unquote more profitable hospital than Nashoba Valley and Carney, which very well could be the case because for hospitals and healthcare facilities that service underserved communities and not wealthy communities, the ability for them to do certain things is going to be difficult, and they don't get the support that they need, either privately or through the public government. We also think, just no surprise, that the way that we can really robustly try to figure this out is that if we had, for instance, Medicare for all in Massachusetts, we would have the funds, no question, to be able to purchase Carney and Nashoba Valley and for the state to run them. We could do it without it because there is a fairly significant rainy day fund that the state of Massachusetts has now. The other piece that I just like for everybody to know, and they may not know it, is that we've outlined there's seven or eight public health facilities in the state of Massachusetts that are now publicly owned, run by the Department of Public Health. For our perspective, the issue of eminent domain is the difficulty we had in factories was who's going to run it afterwards, who's going to be management, who's going to be sales, who's going to be the engineering team. We knew who the rank and file members were going to be, but who was going to be that management level expertise. And you were trying to save a factory. Here we're trying to save a healthcare facility that the state has a lot of experience running. They've run public hospitals for decades in the state of Massachusetts, so it's not an unknown quantity. The other piece that I would just, before I quickly lay out some points that MassCare, you folks should know that MassCare is thinking of, is that with eminent domain and healthcare, there are two issues that, from my perspective, have a lot of solidarity with each other. Number one, eminent domain is a known quantity, as is Medicare for all. Number two, both issues are issues that are critical for our healthcare system in order to be able to thrive and grow. And three is that in every instance that we've worked with around eminent domain, we've looked at owners who are willing to set up more cooperative relationships with the employees. And if we couldn't do a publicly owned factory, although it'd be nice, but we can do publicly owned hospitals. And we can save those jobs and secure those jobs for generations to come. Because of the severity of this particular situation, and having Brother Eaton, Sandy Eaton, sort of give mass care chapter and verse as it was happening, the closing of Quincy after Steward bought all of the facilities a number of years ago. Mass care has sort of taken a position, right, that we should not be losing any more facilities, and that we should do whatever is within our power to push the government, to push the governor, to push the attorney general, number one on the governor's end, to seize Nashoba Valley and Carney, to take them by eminent domain, and if they can't find a buyer, to run it as a state facility, which we have lots of history doing that. Secondly, for the attorney general, we really think that they need to follow the law. Steward needs to follow the law. There's a 120-day notice requirement. We think that actually started August 7th. So we think we have quite a bit of time. Steward is saying they're going to close the facilities the end of August. Don't know. That's what they say. So we think that we should put additional pressure on the attorney general to force Steward to follow the law. We don't understand why the state is letting Steward sort of call the tunes. Bankruptcy court is a little bit different situation, but the state is a state, and the state has its own policies and programs that it has to do. And it has its own laws on what companies are required to report or required to do prior to closing a facility. Steward's not doing it. And then finally, mass care. We had a meeting last night of a hospital task force. We're having another meeting a week from tonight at 7 p.m. If you get a hold of mass care, we can get you the link, the Zoom link for it. And we're developing a strategy and some tactics around how to put additional pressure on the governor and on the AG to do the right thing in this situation. And for us right now, any tactic is on the table. No tactic is off the table. We think that we really need to up the ante on this particular question for two reasons. One, I think it's really healthy for us for people to see eminent domain in a light better than, say, building a power plant, a power line, or building a highway and destroying communities. That this is actually a life-saving, literally a life-saving endeavor that we're embarking on to get these hospitals saved. We want to do it in conjunction with the folks who are representing the communities in the Nashoba Valley and Dorchester, Mattapan, the folks that are serviced by Carney. So we're continuing to work on this issue. It's a priority for mass care right now. And we've been getting a lot of support for it. And again, this is because politicians are used to the issue of eminent domain. This is not an unusual situation for them. They know this issue chapter and verse. It's just oftentimes they're using it to destroy ourselves, not to help us. So I'll leave it there, and I'll take any questions.
Fabulous. Thank you so much, Peter. Steppy, you're up next. Dr. Steppy Woolhandler.
Okay, I hope everyone can.
Yes.
Yes.
Yeah, we can see them. Yeah, that's great.
But I'm not sure I can advance them.
Cool.
Okay, let's see.
Oh, there we go.
Okay, all right. I'm a physician. We always start meetings by talking about financial disclosures. I don't have any financial conflicts of interest. I have worked as an unpaid policy advisor for both Bernie Sanders and Elizabeth Warren's presidential campaigns in 2020. I've recently collaborated on research with Elizabeth Warren, and I co-founded Physicians for a National Health Program. I'm going to talk a little bit about what private equity is, which is a story about how we got into this problem. Private equity is an investment firm that does not sell stock on so-called public stock exchanges. And consequently, they are exempted from many of the rules that other corporations have to follow. And this exemption allows them to operate in real secrecy so that you can't figure out what the heck they're doing. And private equity is like the market on steroids. It's like for-profit hospitals on steroids. And I just want to remind people what the problem is with the market and healthcare, and it's the so-called inverse care law by British GP, late British GP Julian Tudor Hart. The availability of good medical care tends to vary inversely with the need of the population served. This inverse care law operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. And private equity is like capitalism on steroids. It exposes everything in its path to market forces and causes very unequal distribution of positive resources. Now, private equity has been increasingly involved in healthcare with over $1 trillion in investment over the past decade or so, particularly right around the time of the pandemic. And currently, private equity owns a big chunk of the U.S. healthcare system, about 4% of hospitals, including the Steward system, or was the Steward system, 11% of all U.S. nursing homes. There's one private equity firm that controls 25,000 emergency room clinicians. Private equity owns 1,300 women's health practices, about 8% of hospices, dermatologists, gastroenterologists, 10% of medical oncologists. One of my daughters is a medical oncologist, and 15% of radiation oncologists, and 18% of all 1,800 anesthesiologists. So a lot of the medical resources in the United States are being bought up by these secretive, aggressive private equity investors. They're buying up substance use facilities all over the country. And these are just the percentages of all substance use facilities in various states now owned by these secretive private equity companies. And a huge share of all mental health facilities, including like a shocking quarter of mental health facilities in Colorado, Texas, and North Carolina. So these are big players. But I want to talk about what happens with hospitals and asset stripping, sucking the resources out of a hospital is a key private equity strategy for quick profits from the hospitals and nursing homes they buy. And this, of course, is what has happened with the Steward system. It was previously Caritas, owned by the Archdiocese. It was bought by a private equity firm in 2010. In 2016, the private equity firm sold the real estate out from under the Steward system. So all of the buildings, all of the land is owned by a private real estate company that's separate from the Steward system. And of course, that's complicated the situation in Massachusetts. And that hollowed out the assets, hollowed out the resources of the Steward hospitals, and they were left paying huge multi-million-dollar rents for facilities that they had, a month before been the owners of. This private equity system used the $1.2 billion it got by selling off the real estate to repay itself and its investors, and leaving us with these hollowed out, financially weak hospitals. This is not unique to the Steward system. This was some research we published in JAMA just 3 weeks ago. It was, in fact, inspired by what we understood about the situation with Steward and Cerberus and selling off the real estate. But we actually identified 156 private equity acquired hospitals nationwide. It's as many as we could find that had sufficient data, compared them to 1,560 matched hospitals in a process called a difference in difference event study method. But we did find that in the years after private equity bought a hospital, it was stripped of 25% of its total assets. So it's a ubiquitous strategy when private equity buys hospitals and nursing homes to hollow them out and weaken them financially by essentially selling off all their assets, turning the profits over to investors. Quality also deteriorates when private equity buys a hospital. This isn't our work, but it's fairly similar work by some local folks at Harvard. After private equity buys hospitals, when they compare the ones they bought to the control hospitals. Hospital-acquired complications goes up 25%, including 27% increase in in-hospital falls, 37% increase in central line infections, and 150% increase in surgical site infections. They hollow out the hospitals financially. They charge them high rents. They force the hospitals to cut back on supplies and nursing care, and this leads to more complications. I'm going to skip that. Something very similar happens when private equity buys nursing homes. This is what happened when the Carlyle Group bought Manor Care, which was a string of nursing homes, second largest chain of nursing homes in the country. They bought it in 2007 for $6 billion in a leveraged buyout, which meant the nursing homes, but not the private equity firm Carlyle, was responsible for the $5 billion debt. In 2011, the private equity firm sold off the real estate out from under the nursing homes. They paid off the investors, and the nursing homes were stuck with $500 million annually in rent on facilities they'd owned the year before. Okay. Following that, the nursing homes were broke. They had to lay people off. They cut costs. They had soaring quality violations. And in 2018, Manor Care filed for bankruptcy. The CEO granted himself $117 million in deferred compensation. Sounds familiar? Well, that's the exact same playbook we saw with the Steward system and after private equity purchased it. And then here again, this is a national study looking at the quality of care for patients. And not surprisingly, after you've hollowed out the nursing home, the mortality rate went up, the use of antipsychotic medications, which need to be used very rarely in nursing home patients. They were being used all the time. The staffing fell, the nurse staffing fell, and the taxpayer costs borne by you and me as taxpayers actually went up by 11%. That's not the only private equity strategy. Just very briefly, when private equity buys specialist medical practices, monopolization and price hikes are the key to their private equity strategy for quick profit. So they buy up all the practices in an area, get a monopoly, and hike the prices. This is just the share of all MSAs, metropolitan statistical areas, where there's a large share of a given specialty that's owned by a single private equity firm. So for instance, in gastroenterology, about 20% of all metropolitan statistical areas have a private equity firm that owns a giant share of all the gastroenterologists, allowing them to hike the prices. And this is just a slide, I'm sorry, it's very complicated, looking at what happens when private equity buys gastroenterology, dermatology, OBGYN, or ophthalmology practices, the prices go up. Okay, now what happens when private equity buys primary care practices? Well, upcoding, that is scamming the federal Medicare program, is a key private equity strategy when private equity buys primary care practices. What am I talking about? Well, there's this model in primary care of like high touch primary care where they're someone's seeing the patient all the time, lots of wellness, so-called wellness benefits, but they focus on patients in the Medicare Advantage program where the taxpayers give a premium to the Medicare Advantage plan for each enrollee. Then they get their primary care doctors to do very intensive upcoding. They do stuff like screen with ultrasounds, and when a positive test would boost the premium the taxpayers pay to Medicare Advantage by as much as $2,800 per patient per year. They offer the primary care providers bonuses just for using software that automatically upcodes and says the patients are sicker than they are. And Oak Street, which is now owned by CVS Aetna, gives the primary care physicians a scribe who's specially trained in upcoding, an upcoding scribe, all allowing the primary care practice or the HMO or the firm that owns them to claim people are much sicker than they are and scam additional payments out of the Medicare program. And the end game has been to sell to major insurers who use the affiliated practices to boost profits and to launder excessive overhead and profits. The insurers are limited to 15% overhead and profit, but by owning these primary care practices, they can make the patients look sicker and launder excessive overhead and profits. And just a very prominent example, this is actually United Health Group, United Health Care, which is the largest U.S. insurer. It covers about a quarter of the adult population of the United States. It's also the largest Medicare Advantage insurer. Through its Optum division, it has been very active in the Boston area. It now owns the Atrius Group, and they were thinking about bidding on the Steward Physicians Group. There were some antitrust issues that they were threatened with, and they backed out. Okay, so what we're talking about is a situation with private equity, which with profit-driven healthcare, of financialization, where money becomes the mission. Like traditionally, providers invested money in buildings and equipment to produce more medical care, which I would call our service mission. Now financial entities invest in medical care merely to produce more money, i.e. profit. So money has become the mission. Now, I don't want to let the nonprofits off the hook. They misbehave in major ways, as we all know. But I just want to give you this example of Johns Hopkins Hospital. I mean, a really important academic medical center, nonprofit in Baltimore. But when somebody doesn't pay a debt to Johns Hopkins hospitals, they garnish their wages. And the union there looked at the court filings and said, well, who employs most of the people whose wages are getting garnished? And it turns out the two top employers of people with garnished wages were Johns Hopkins University and Johns Hopkins Hospital. So literally pursuing people, garnishing their wages and garnishing the wages of their own employees. So I'm just saying the nonprofits need to behave as well. Finally, I just want to say that this underlines the point that Medicare for all is not enough. I'm still a big believer in Medicare for all, but we need to address the patient Peter brought up. Who owns the health institutions? We need to have real community control, not just of the finance, but of the health institutions themselves to prevent a fiasco like is now occurring with the Steward system. So I look forward to questions a little bit later, and let's hear what Savina has to say.
Yes. Wow. That's wonderful, Stephanie. Savina, yes.
Thank you. Thank you all for having me. And of course, I'm going to be sharing my remarks alongside Karim. He's here. He's going to introduce himself when I'm done, and he'll wrap us up. So a couple of things. I just want to start off with a couple of slogans we used to use, right? We only get what we are organized to take. And as you see what I have on here, fight poverty, not to poor. So I was raised in Roxbury during the 60s and the 70s. I understand and have witnessed and have been a part of the victimization, the sin against God of redlining and gentrification when my families lost their home to a block of our neighbors' homes were taken for a highway that was never built. We all know
exactly.
that.
Oh God, Bromley Heat.
Oh my
Sure,
goodness.
yeah.
That's right. By the end of the 80s, I began organizing around some prolific organizers from the National Union of the Homeless. And I come out of the housing takeover movement when we were taking over abandoned housing all across this country to call attention to people sleeping in the doorways of the subways. Rents were sky high. We couldn't afford it. And we used another slogan that said jobs in homes, not death in the street. So that's our demand. Those were our demands over a course of several years. And we also had a treatment on demand coalition for substance users seeking recovery beds. So today, here we are with the Poor People's Campaign, and we're partnered with MAPA and Fund Healthcare, Not Warfare, on a few fronts. I remember we worked alongside Sandy when the nurses were striking. And I'm saying that to say that right now, I'm going to start off with a couple of words. There is no time to waste. Healthcare is a human right, and yet in our nation, it often feels like a privilege reserved for those who can afford it. Steward Health Care, like we're all talking about, like many for-profit healthcare systems, has consistently prioritized profit margins over people. This profit-driven approach perpetuates a cycle of poverty by denying essential services to those who cannot pay. And I just want to paint that picture. We know that Carney Hospital, that's located in the Dorchester neighborhood of Boston, serves a densely populated and diverse community, home to over or about 130,000 residents or more, right? We've got to do our research. The Nashoba Valley region, which includes towns like Ayer, Groton, Harvard, Littleton, I'm sure you all know, Pepperell, Shirley, and others, has a population of about maybe 50 to 60 residents. Don't quote me. The closure or this reduction of services, what will it do? It will force our vulnerable residents to travel farther for care. And if they can't access it, and if they can access it, maybe at all, right? Putting their health and lives, of course, at greater risk. This is not just a healthcare issue, it's a social justice crisis, where the needs of the poor are always sacrificed for corporate profit, leaving us with the least to bear and the greatest burden. We know that poverty leads to death, according to David Brading, a professor of public policy at the University of California, Riverside, that concluded that poverty is the fourth leading cause of death in the nation. Despite what or how Governor Hill is moving on the Commonwealth's most vulnerable communities, we need to apply pressure, more pressure. This is fast. The pace is going to explode, but there is no time to waste. This is a catastrophe. And with the threat of hospitals at risk of these sudden closures, again, Steward Health Care has been a clear and present danger impacting the most vulnerable residents impacted by poverty, racism, and yes, militarism. But who benefits and who suffers? And how does this reflect the broader injustices of our society? We need a new and unsettling force. We need organizations like the Nonviolent Medicaid Army, who you'll meet Karim in a minute, organizations like the National Union of the Homeless and the Poor People's Campaign to continue merging and partnering with all of us, right? We can't do this alone, to build from the bottom up. If Steward Health Care were to close Carney Hospital or significantly reduce its services, it would directly impact a large portion of the population, as we all know, particularly those who depend on the hospital for accessible and culturally competent healthcare. This impact would be most severe for all of our low-income families, elderly residents, and communities of color who already face significant healthcare disparities. And the loss of Carney Hospital will force many residents to seek care farther away, increasing travel time, and who has bus fare? Healthcare costs, and who has that? And potentially delaying necessary medical treatment. Imagine someone seeking help from substances. Where are they going to go? This would exacerbate existing inequalities in healthcare access and outcomes, with far-reaching consequences for the overall health and stability of the Dorchester and Nashoba communities. And Steward Health Care is more than just a healthcare provider. It is a reflection of the broader injustices that plague our society. And by perpetuating poverty, exacerbating racial inequities, and embodying the values of a militarized community, Steward falls in its fundamental mission to care for the people. It's a sin. It is time for us to demand a healthcare system that truly serves everyone, not just the rich, especially the most vulnerable among us. We must fight for a future where healthcare is recognized as a human right and not a privilege for a few. Let's talk about a call to action, because there's no time to waste. We must mobilize and stand at this critical juncture in the fight for healthcare justice. The ongoing crisis with Steward Health Care's actions in communities like Nashoba Valley is not just a local issue. It's a glaring example of how corporate greed tramples the rights and lives of the poor. And as members of the Poor People's Campaign, we must partner and rise up and demand accountability and change together. Remember, this is an election year. And on March 4th of this year, the Poor People's Campaign and here in Massachusetts coordinated simultaneous letter deliveries to over 32 states across the country. And we still can vote you out, up and down the ballot. We call on everyone, every resident, healthcare worker, faith leader, and allies to mobilize. We must hold Steward Care, healthcare accountable for the harm that they are causing to our most vulnerable neighbors. Attend town halls, for example, organize community meetings, and rally, like you all have been, outside of Steward facilities, making sure all low infrequent voters are on the ready to cast their ballot. We need to flood our state representatives and senators with calls. This is a continuation, right? You're not doing this right now. This isn't new, but here we are merging together across the state and demand that we step up to protect the communities. We have no time to waste. State representatives that have been involved or expressed concern, maybe Rep. Sheila Harrington and Senator Jamie Eldridge, who have shown a commitment to healthcare in our region, we can contact them. But right now, I want to introduce you to Karim to say a few words. Karim, you've got the floor.
Hi, thanks for inviting me, Sabina. I'm grateful for your comradeship. And I really appreciate all the study that went into this. I think that's something we really value in our network. I sort of come out of Put People First Pennsylvania, which is one of the many, many, many seeds of organization planted by the legacy that Sabina grew up in and is referring to in the National Union of the Homeless. And the sort of like those seeds have taken root all over the country. And I'm sort of one product of that and sort of my formation. And so the Nonviolent Medicaid Army is organizing specifically what we conceive of and what Sabina is referring to as the leading social force, right? That's who we talk about in the Poor People's Campaign, the 140 million, the people who have little to lose and everything to gain from a fundamental transformation of society. So I appreciate the call out of private equity, the sort of material bases for that exploitation, which we need to understand in a really sophisticated way, because our enemy is sophisticated. I also appreciated the call out to manor care, because in Pittsburgh, when we were in Pennsylvania, and I appreciated the call out. Thank you for that work that you're doing on the quality of the care deteriorating. We had a member, her name was Monroe, and they left her mother to sit in her own feces, and she had to go every single day to try and clean her mother because none of the staff had the ability to do that. That's what we're talking about here. That's the devastation that's being visited on our communities and on our neighbors, and will be visited on us. We're not on everyone. This is coming for all of us. And so when we talk about organizing the leading social force, we have to inseparably connect our study and our understanding of the system to the people who have an interest in fighting these fights. We have to understand and have a plan and a vision, and we have to relate that vision to how we spend our time. And a crucial component of that is doing base building and bringing folks into our organization so we can relate to them and have the power to fight back against these monstrous systems. And the Nonviolent Medicaid Army, which is in a very early phase of development in Massachusetts, but is more advanced in the 10 other states, is just like one expression of the work that comes out of this legacy from Sabina.
Thank you so much, Karim. We so appreciate it. We're going to open it up to questions from the floor. I don't see too many in the Q&A. So why don't we just have people raise their hands and ask their questions? Whoops. Here we go. Any hands? Does anybody? I can't see everything on my screen. So.
Maria Termini has a question.
Oh,
Sure.
Maria. Yes.
Yeah. My question is for Sabina and Karim. I hear you talking about the nonviolent Medicaid army. I would like to know why it can't be the nonviolent Medicare army, and why
That's
we
right.
can't get the insurance companies out of the mix and get rid of them and their corporate greed. Why can't we go for Medicare for all? And I would really like to see if the Poor People's Campaign can come out and say Medicare for all, because Medicaid is subsidized and the insurance companies are still in the mix. So I'd like your comments on that, please. Thank you.
Now, would you like me to speak to that, Sabina, or do you want to go first? Thanks for that question. We get that question a lot. I think I'm in favor of Medicare for all. I'm in favor of single payer. These are important policy solutions to the sort of diagnosis of the problem that we all share. We organize the nonviolent Medicaid army because there are 20 million people getting cut off of their Medicaid. So the formulation is related to who we are organizing and how we are organizing them, rather than a specific policy solution. It's related to our theory of change and how we spend our time.
Okay, we have Nancy Goldner.
I was very struck by the use of the word take. I don't know if folks remember a movie called The Take some years ago about a group of workers who took over their factory after it was being closed. Oddly enough, after it became successful, the owner wanted it back. In any case, I'm very in favor of worker ownership. And I was wondering if when we speak about community-owned public health facilities, hospitals, nursing homes, and so on, if we can also promote them as worker-owned, or is that not ever talked about?
Well, maybe I'll take that. I mean, I think we need to figure out what community control really looks like. And I think we want the people who work in a facility to have a say. We want the patients who get their care to have a say. And we want the communities where these facilities reside to have a say. And, it's not as simple as saying the state's going to take it over or the workers are going to take it over. It's actually a question of getting those three groups, the patients, the workers, and the community surrounding it, to figure out a governance structure that really means community control. What we have now is obviously not working. We have a system that's very profit oriented. Even our nonprofits are misbehaving, trying to cherry pick patients they can make money off of, exaggerating how sick people are. So we need to be thinking about what it means to have real community control of the healthcare system, because we all, whether we work there or just get our care there, we all rely on the healthcare system to help keep us healthy.
Peter or Sabina, would you like to comment?
No socialists in the group? I'm sorry.
Looking for socialists. And Sandy, any comments?
Yeah, I was just looking for a hand to raise on my screen. A couple of days ago, Massachusetts Governor Maura Healey, who was the Attorney General through 8 years of Steward's criminal action, and they were never held accountable by either by her or by her predecessor. But anyway, she said that we couldn't take these two hospitals by eminent domain because we don't have a system in place to take them over. And I was just wondering if anybody wants to reflect on that, the need for a system. Peter's pointed out that we have a public health system in Massachusetts that could do that. I'm also thinking of the people like Bill Walsack, who founded 40 years ago, founded the Cobbin Square Community Health Center and served as its CEO for most of its existence. And very optimistically, rosy-eyed, tried to get, it worked for a few months as the CEO of Carney Hospital, and who tried to get things into get the hospital to meet more urgent health demands of the community. And he was not allowed by Steward. So they parted company after a number of months. So, I mean, the whole thing is, do we need systems? Do we need public systems? And certainly I'm in charge. Yes, I'm proud of my socialist heritage. And I certainly think that workers taking over things are important. I think workers have to take over the whole state and direct the whole system, and not just try to pick it off the low-hanging fruit piece by piece. So we're stuck with the least viable and least profitable enterprises, but in fact are going to redesign the whole system and the whole society in terms of all of us. Just to throw off, I just needed to respond to the socialist in me.
Jonathan has a
Jonathan
question.
King.
Yep.
Yes.
Hi, thanks so much. Excellent presentations. I just want to remind people, this is my imagination, I mean, there is a very long history in the United States of federal and municipal and state governments running hospitals. Boston Medical Center was the Boston City Hospital, was run by the city of Boston. Cambridge City Hospital was run by the city of Cambridge. The Forest Hills facility was built by the state to make sure vaccines could be developed. The first public health hospitals were built by the federal government, right? Now, it's true that that it was created, that was the Catholic Church who ran the hospitals that Steward bought. But there's a very long and deep history of state governments running hospitals, and we just ought to demand, that's nothing new, we just ought to demand, return to the public health needs of the community being served by the public.
Yeah, I mean, I would agree with John. I think it's kind of a bullshit answer to say we don't have a system after there's Boston Medical, there's Cambridge Hospital, there's public hospitals all over the country. They don't run perfectly. They ought to, I'd like to think we could try to run things better with more community input, more worker input. But to say we don't have models or ways of doing it is just not true. And I agree with John on that.
I have a question. I
Yes,
can't
Carl.
read. Yeah, I live in Rosendale, and I live right near the Faulkner Hospital. And the Faulkner Hospital was acquired by Brigham and Women's about 10 years ago. And now they are building a massive expansion on that hospital. It has to be a, $20 million project. It's going to double the size of that hospital. They've been working at it for a year and a half. It's crawling with construction workers every day. So I'd like to talk about the capital flows, because I am told that Brigham and Women's has a higher reimbursement rate than the Steward chain does, right? So
They do.
by taking over what was formerly a community hospital like the Faulkner in a high profit chain, and then directing capital to it, now they can make money off of that. It's just about 5 miles away from the Carney. It's not exactly the same neighborhood, but it's pretty close. And it's just striking that we have like a total disinvestment, and we're going to close the Carney. And meanwhile, we're building a new facility in Jamaica Plain.
It is frustrating, no question. Any other thoughts or comments by anybody else here?
So
For hands, yes. Yes, Peter?
So I just wanted to sort of amplify a couple of things that were said that I think are critically important. One is we noticed through discussions in mass care a little while ago, and I'm really glad, Steffi, that you and the others put together that paper, because I think it's pretty important. Realize that even if we had a single payer system in Massachusetts tomorrow, it could be held hostage by the companies that own the facilities. So even if we got it, it potentially could never be implemented. So we realized that this question of infrastructure and and this is the second point I was doing, I actually don't think you can have a really coordinated infrastructure and attempt to build infrastructure that makes sense for our communities for healthcare without some kind of a coordinated single payer system in Massachusetts that brings the revenue into the state on a consistent, regular basis that can be anticipated, whose growth can be anticipated, and where it can be quantified in a more readily identifiable way, and where the profit is completely taken out of the system. And I think that in order for us to be able to have single payer, we really have to figure out this infrastructure piece. And it's one of the things that MassCare is dedicated itself to doing this next legislative session when we rewrite the legislation in the state, is to address that issue with our infrastructure a little bit more explicitly. And especially the Steward with, the situation with the Steward crisis has really amplified that a lot. And I'm somewhat surprised, but maybe not completely, that the private equity firm owned the Doctors Group now was sold to another private equity firm that is going to own the Doctors Group. So apparently private equity isn't banned in the state yet, so hopefully it will be shortly. But I just wanted to throw out those thoughts.
Yeah, and that might be a campaign we need to take on. Alan Sager talks about the $45 billion that are spent every year in Massachusetts on healthcare. And a redistribution, a new structure to be able to, that's all private health insurance, combination of factors. But the money is there. It's just got to be reallocated and redirected for sure. Anybody else have
So
any
in the
thoughts,
chat, there's a
comments?
question from Kareem actually, and another one from Rosemary.
Okay. Rosemary and Kareem, speak up.
Oh, I was wondering Bonnie, I think it was you mentioned like a prior fight against Steward. I didn't know. Maybe not. I'd love to hear about
2010, they closed, 2014, they closed Quincy Medical Center with essentially 1 week notice. And we got a negotiated settlement of an emergency room for another year. The hospital is now a high-rise deluxe condo on the hill. So that is, and it's 100,000, over 100,000 residents. And that's what we have. There's a condo on the hill. So yes, we hate Steward. We've had too many Steward experiences here. Yeah. Yes, and Rosemary, you had a question.
Yes. Hi, everybody. I'm aware that my state senator, Nick Collins, he's been very vocal and talking about what should be done, including eminent domain. But my state rep, and I don't think any state reps have been talking about this. So I was wondering, should we be after them? And if not, what else should we be doing?
Yes, please jump in. Peter? Anybody? Sabina?
So, the state reps all got a copy of the white paper. It's also, they can get a copy of it from the MassCare website, which lays out the legal analysis and the legal justification for eminent domain. But as I said before, they all know it. They all know this. This is not rocket science. It's been around for a couple hundred years, probably based on Old English law back in the 1100s. It's been around for so long. And it's a well-established law. There's two reps. There's reps from New Bedford and Taunton who have been through this before. Senator Mark Pacheco supported our attempt to take Hascon Corporation by eminent domain in Taunton a number of years ago. In New Bedford, we had the whole delegation, Tony Cabral, Mark Montigny, a whole bunch of other state reps who supported taking J.C. Rhodes by eminent domain in the mid-90s, and prior to that was Morse Cutting Tool. So the state reps, and I would absolutely encourage you to contact the state reps and the state senator and talk to them about, if they can do one, they can do three. This is really not rocket science. And it is
And we
not
can still
this
declare
issue
emergencies,
around
public
eminent
health
domain is not
emergencies.
a
Yeah.
battle that will that will
Yeah.
just keep going on and on and on and on. There's a very
Mhm.
clear end to it, and that is when the hospital closes and the equipment leaves, it's done. And that is what we need to try to prevent. We always knew from our own experience in the UE that once the machines leave the plant, it's done. There's no, you
Yeah.
can't bring it back. So that's we know, so that's why we're sort of pushing the pedal to the metal right now, trying to figure out as many ways as we can to put as much pressure as we possibly can on the Healy administration and on Andrea Campbell to do the right thing and to challenge Steward and to get them to follow the law. But absolutely, I would contact state reps and talk to them about eminent domain, and that's how you seize those facilities and keep them open. That may be the only way we can do it, but it's so readily available to them. It's not funny.
I mean, the
Jonathan has
silence.
another comment. Yeah.
Hello?
Jonathan, yes.
The silence of our state reps, it's a scandal, right? I mean, there should have been a press conference with 50 state representatives calling on Healy, calling on Campbell, or calling on their own leadership to move on this, right? Just silent. And so I absolutely think that we ought to write to them very strongly and with full moral voice that this is outrageous. They're standing by, while hospitals burn.
Mhm.
Yeah, and it's just
Yes,
it's the
Savina,
same
yeah.
old behavior. It's the same, right, Jonathan? It's the
Yeah.
same old behavior, and sometimes I feel like over the years I feel cynical and crazy just trying to hold on to this as we see this this cycle of profiting off of people's pain, right? It's just been going on forever, right? And rise up and just shake them out of it, right? We're going to have to do something that's going to twist them as much as they twist us, even if it's to lay our bodies on the line to hold on to it for a moment. Yes, we live in this system. We live in a capitalist system run by the patriarchs that continue to do this to us over and over and over again. The definition of insanity is doing the same thing over and over again and expecting different results. And we've got to jump off of that cycle and, really come together to strategize and mobilize and take action, as well as they're taking action off of us without giving us even a letter to be a part of the decision-making process. So this is theft. It's theft. Yeah.
No question about that. Any other thoughts or comments?
I mean, forgive me, but the federal government just sent another $20 billion of arms to Israel.
Oh, yeah.
Right. So there's plenty of money in the system. And the Faulkner is another example where they're letting the private hospital marketplace,
The richer
build a new hospital in a high-priced way while closing down hospitals that serve Black and brown folks, primarily, not entirely working class folks. And the government and all these state reps will do nothing about it. Oh, it's just the market operating. We can't do a thing. It has nothing to do with us. So they're in the grip of a neoliberal ideology that they worship the market, and they see those consequences. They wring their hands. Oh, isn't it terrible? But they're not going to do anything about it. And that goes all the way up to Governor Healy and the rest of them.
True. Yep. Well, let's hope we have, Bruce. Here, I see a hand. Bruce? Fleischer?
Sorry about that. Again, I want to agree with some of the last comments people have made. I'm part of the mass care group with Peter putting out that thing. And I actually think we should have been sitting in at Healy and Walsh's office. And if people don't know Walsh, she spearheaded the anti-safe staffing thing for the hospital establishment. And I think, you know, I mean, these state reps are useless. For every Jamie Eldridge, there's 20 that are completely useless. And I think we need to, you know, Massachusetts has the least competitive process in terms of people run unopposed all the time. And the same people who are terrible in healthcare are terrible on war, are terrible in all this stuff. And we need to get a bunch of people to primary these people. And even if it's just talking about this debacle around Steward, of which I'm retired from 1199, I represented some of those hospitals. And, you know, this is the chickens coming home to roost. These people were criminals from day one. But I mean, we need to stop primarying. So this stuff is out there for people because I think people want to hear this. And we need to get people, not a geezer like me, but get some young people out there to run against some of these people because these issues need to come up, whether it's the genocide in Gaza or whether it's no health care for people. Like Bill Walczak said, if this was Newton Wellesley Hospital, we wouldn't be talking about this.
Right.
So it's a class issue. It's an issue of the market and the last gasps of neoliberalism. So, you know, I think we need to get out there, and because people are not running against these idiots, and we need people to get out there and, you know, get the issues out. So start reaching out to people, you know, who can run against these people.
Thank you, Bruce. Any other thoughts and comments? We'll wrap this up. Just for last thoughts. Okay, well, I want to thank the speakers. We're so thrilled that we have such national experts. Steffi, we've got Peter, and we've got Sabina and Karim. So we thank you so much. We know we're all going to be working hard on this issue. It's not going to go away. We will fight the good fight. But yes, we've been down this road before in Quincy. And so Steward fights very hard. Rosemary, yes. Oh, I saw a hand.
Sorry,
Bruce?
I was just clapping for our
Oh,
presenters.
clapping. Okay, there you go. We'll clap for all of our wonderful speakers. We thank you so much and keep up the good fight. We just cannot let it go. We just have to continue to keep on keeping on. So let us hope we will achieve some success on that front. With mass care in the lead, we know we're in good hands. So we will
Amen.
follow your leads, everybody.
Amen.
Good
Thank you,
night.
Mom.
Take care.
Good
Thank
night.
you.